Hello guys, I am Dr. Navneet. Today we are going to start with our second part of the rapid revision. In the first part, we have already talked about the conceptual topics, so the second part is going to be easier. It is mostly about systemic pharma. So the first chapter is respiratory system here, and we are going to talk about the bronchial asthma. Now, what is bronchial asthma? It is a chronic inflammatory airway disorder. It is a chronic inflammatory airway disorder with reversible bronchoconstriction. That means the bronchoconstriction can be reversed. So here you have to treat things. One is the bronchoconstriction and the second one is inflammation. So this is going to be the aim of our treatment. Now, bronchial asthma is a type 1 hypersensitivity reaction. Why? Because it is an allergy. Now, how is this allergy happening? Whenever there is first exposure to the allergen, this allergen is picked up by an antigen presenting cell. It has an MHC that will show this allergen to the T helper 2 cell. Now, what will this T helper 2 cell do? This will release interleukin 4, interleukin 5 and interleukin 13. Interleukin 4 will bind to the interleukin 4 receptor. Yes, this interleukin 4 receptor is present on the B cells. Now, it will do something known as isotype switching. What does this mean? See, B cells already have IgM and D on the surface. These are antibodies. You know, B cells will produce the antibodies. They already have M and D on top of them. Now, it will be converted into other classes of the antibodies. That is why it is known as isotype switching or class switching. Yes. Now, what is important here is whenever this allergen comes, it will release IgE. It will release IgE. We have all these antibodies G, A, M, D, E. Yes, it already has M and D. It will produce G, A and E. Here IgE is important. This IgE will go and bind on the mast cell. Okay. This will sensitize the mast. Now, how is this IgE attached on the mast cell? It will sit here very nicely. Yes. So, you can see here, this is how IgE is going to be attached on the mast cell. So, this is what has happened during the first exposure. Yes. Now, this IL-5 will activate eosinophils. It is given in the name itself. 5 means fifth alphabet, that is E. It is eosinophil. IL-13 will increase the mucus production. It will increase the mucus production. This is what is going to happen in the first exposure. Now, in the second exposure, when this same allergen comes, the mast cell is already sensitized. That means it already has IgE antibodies on top of the mast cell. Now, what will this allergen do? This allergen will sit in between this antibodies and it will cause degranulation of the mast cell. Once the mast cell is degranulated, it is going to release histamines, prostaglandins and leukotrienes. Now, what is histamine doing? All of you know it will cause inflammation and bronchoconstriction. What is prostaglandin doing? It will also cause inflammation. What are leukotrienes doing? It will also cause bronchoconstriction. But what is important, you have gotten your aims of treatment. How are you going to treat it? See here, I told you, you have to first treat the inflammation here. Yes. How can you treat the inflammation? Obviously, the best drug for inflammation is always steroids. Yes, but steroids are very toxic. So here you will give inhaled corticosteroids. That is how you are treating the inflammation. So this is the first class. Now, how can you treat the bronchoconstriction? By bronchodilators. What are the bronchodilators that we have studied? But what is the best bronchodilator in bronchial asthma? It is going to be beta-2-agonist. We have studied SAMA, LABA, VLABA. Yes, SABA, LABA and VLABA. Got it? Now, next is coming to be muscarinic antagonist. That also we have studied, if you remember. SAMA, IMA and LAMA. Yes, ipratropium, tiotropium, all of these. Now, we also have one more drug that is also known as theophylline. That is also known as theophylline. If you remember, I told you a point about theophylline in the general pharma. Erythromycin is a enzyme inhibitor. When you give erythromycin along with theophylline, it will cause theophylline toxicity. This is what I asked you to remember. Yes. Now, so these are the 4 classes of drug. We are finished with the 4 classes of drug with inflammation and with bronchoconstriction. Now, if you see here, leukotrienes will act on leukotriene receptors. Leukotriene will act on leukotriene receptors. So, we can give a drug called leukotriene receptor antagonist. Leukotriene receptor antagonist. These are what are known as what? These are the drugs that you commonly take: montelukast and zafirlukast. So these are all the classes of drugs. Now, if you go a bit further, you can see here, because of mast cell degranulation, all of this is happening. So you can also give mast cell stabilizers. Mast cell stabilizers. If you block it from degranulation, obviously you can treat it. Yes. So these are what are cromolyn sodium drugs. Yes, this is mast cell stabilizer. Now, if nothing works, we are going to give monoclonal antibodies. Monoclonal antibodies. Now, how can you remember these monoclonal antibodies? It is IL-4 or IL-7 or what is it? That is why I told you all of this pathology, so that your pathology is covered and your pharma and medicine will also be covered from this one single diagram. So, if you see here, IgE is acting, IgE is binding to the mast cell. So, you can give an antibody, monoclonal antibody against this IgE, that is what is known as omalizumab. Omalizumab. Now, IL-4 is binding to the IL-4 receptor, so you can give an antibody against the IL-4 receptor. Against the IL-4 receptor, this is what is known as dupilumab. This is what is known as dupilumab. Now, IL-5 is again acting on IL-5 receptor on eosinophil. You can also block this IL-5 receptor by giving benralizumab. Benralizumab. Did you understand? So these are all the important monoclonal antibodies: omalizumab, dupilumab and benralizumab. Now, there is also one more against IL-5, that is mepolizumab. Mepolizumab. So all of these are monoclonal antibodies. It is given in the name, monoclonal antibodies. So this is how you can remember all the drugs in the bronchial asthma without any mnemonics. How did you remember it? With the help of pathology. So I told you, in the first exposure, it is going to Th2 cell. It will release IL-4, IL-5, IL-13. IL-4 will cause class switching. It will release IgE. IgE will bind to the mast cells. Now, when there is second exposure, there is degranulation. Mast cells will release prostaglandins, histamines and leukotrienes. So, what are the drugs? First, there is inflammation. So, inhaled corticosteroids. Now, there is bronchoconstriction. So, you are giving bronchodilators like β₂-agonists and SAMA, IMA, LAMA, muscarinic antagonists and theophylline. These are the first 4 classes. Then there is leukotriene. So, there you will give leukotriene receptor antagonist. Now, you can also stabilize the mast cell. So, you can give mast cell stabilizers. Next are monoclonal antibodies: omalizumab, dupilumab, benralizumab and mepolizumab. These are all the classes of drugs in the bronchial asthma. Now, what are important points here? Inhaled corticosteroids means obviously you are taking it through inhalation. When you take steroids through inhalation, example budesonide, cyclosonide, if you are taking this through inhalation, it might cause hoarseness of voice. So this is one of the side effects, hoarseness of voice, and it will also cause oral candidiasis. Oral candidiasis. Why? Because steroids will decrease the immunity, so it will cause fungal infections on the tongue. This is what is oral candidiasis. Now, the most important question that has been asked here is, how do you prevent it? You prevent it by using a equipment that is known as spacer. So when you keep a spacer, in between the inhaler and your mouth, this steroids are getting deposited directly into the lungs. It will not stay in the mouth, so it will not cause candidiasis. This is what is important. This is a very, very important question. Yes, this is about ICS. Beta-2-agonist, muscarinic antagonist, that you have already studied in the first chapter itself. Now, theophylline, I asked you to remember when it is given along with an enzyme inhibitor. enzyme inhibitor, that is erythromycin or clarithromycin. This is what the questions are usually asking. What do you see the side effects with these is toxicity of theophylline. What do you see in toxicity of theophylline? Mostly it will cause arrhythmia and it will also cause seizures or epilepsy. This is what I want you to remember. This is what you see in theophylline toxicity. Leukotriene antagonist I have already told you. So that's all about the drugs in bronchial asthma. So now coming to the second chapter, that is the drugs for cough. We have two kinds of cough, dry cough and productive cough. In dry cough there is no sputum, you're just coughing because there is some kind of irritation. So how do you treat it? You treat it by giving antitussives. Why? Antitussives will suppress the cough center, so you will not cough. That's all, treated. Now coming to the productive cough. Productive cough means there is some kind of sputum inside and you're coughing so that the sputum comes out and the infection is relieved. Now let us suppose if you are using antitussives here, then you will stop coughing, the sputum will stay inside, it will build up and it will cause infections. So antitussives are never used here. So what will you use? You will use expectorants and mucolytics. What will mucolytics do? Mucolytics will break down the sputum, make it easier for the sputum to come out. What will expectorants do? Yes, it is throwing the mucus outside. This is what you going to study in productive cough. Now you have to remember few names. We'll see central antitussives, they are suppressing the cough center. In this we have two kinds of drugs. One is opioids and non-opioids. Opioids are codeine, folcodeine. You can see ethyl morphine, morphine, methadone. Yes, side effects is addiction. It will cause addiction. That is the reason why in the general practice you don't see codeine, folcodeine and ethyl morphine. You generally see the non-opioids being used. That is what is dextromethorphan. Dextromethorphan. This is generally used in the central antitussives. Now coming to these peripheral antitussives, they act on the lungs. Yes, so the signal has to come from the lungs into the brain. So if you are blocking it at the level of lungs, that is what is peripheral antitussives. There are local anesthetics like lidocaine and mexiletine, we never use them, and moguistine and prenoxidazine also not being used. Now commonly we are using the dextromethorphan. Now coming to the expectorants, guaifenesin is the most important expectorant that I want you to remember. I told you it will cause bronchial contraction, so the sputum comes out easily. Mucolytics means it will break down the sputum, so it becomes easy for the sputum to come out. It is ambroxol and bromhexidine That's all. This is what I want you to remember. Now there are so many cysteines that you can remember if you want: acetylcysteine, carbocysteine, iridocysteine. All of these are also mucolytics, but important ones are ambroxol and bromhexidine. This is what you see in the syrups. Now coming to the pulmonary artery hypertension, important topic in medicine. Basically it means there is increased blood pressure in the pulmonary artery. How much is it? Different textbooks say different values. Some say it is more than 20, some say it is more than 21. So it is either more than 20 or 21 mmHg at rest in the pulmonary artery when you are measuring it with the help of right heart catheterization. Now what is the most common for this? You don't know. It is idiopathic. But what did the scientists find out is, when do you have hypertension? You have hypertension when there is vasoconstriction. If there is a lot of vasoconstriction, it will increase the blood pressure. Yes, so that is what scientists have figured out. Those people are saying there is increased vasoconstriction and decreased vasodilation. Now, how is the vasoconstriction increased? It is releasing a material known as endothelin. Yes, endothelin will cause vasoconstriction. Now we have vasodilatory factors in the blood vessel as well. These are PGI2, that is prostaglandin I2 analogs. We've already talked about this in the autocoids chapter. Yes. Now it will also decrease nitric oxide. Nitric oxide is a potent vasodilator, so it is decreasing both PGI2 and nitric oxide. This is the reason. Now how can you treat it? You decrease the endothelin and you increase the prostaglandin I2 and nitric oxide. This is the treatment. That's all. This is why I told you all of this. Okay, so we are going to see first, whenever there is vasoconstriction, you always try out with the calcium channel blockers here, that is nifedipine. So you can remember first class of drug is nifedipine. Now once you're done with this, now we are going to come with the main classes of drugs. I told you it is increase in endothelin. How do you decrease it? By giving endothelin antagonist. Okay, so these are ambrisentan and bosentan These are endothelin antagonist. That means it is blocking the endothelin receptors. That's all. Now coming to the PGI2 analogs. So it is analog of prostaglandin I2. We've already talked about it in the autocoid chapter. What are they? Eloprost, epoprostenil and trepoprostenil and trepopostin. Yes, that's all. So these are prostaglandins. That is why you can see the name prost in them. Did you understand? Now there is a PGI2 agonist as well. That means this will act directly on the PGI2 receptor. What is this? It is selexipag. It is selexipag. Yes. Now after this we will talk about the nitric oxide. You can give nitric oxide as a continuous inhalation. Yes, you can give it as a continuous inhalation, but it is not used these days. But we will see how nitric oxide is working. Yes, nitric oxide will activate guanylyl cyclase, and this guanylyl cyclase is increasing the cyclic GMP. This cyclic GMP will cause vasodilation. Yes, so basically nitric oxide, cyclic GMP, vasodilation. Okay, so if you see here, first thing, if you are activating the guanylyl cyclase, will all of this happen? Yes, it will happen. Okay, so that is why we have made a drug called riociguat. We have made a drug called riociguat. So guat means guanylyl cyclase stimulator. Did you understand this? Guanylyl cyclase stimulator, that is riociguat. Now coming to the PDE5 inhibitors. If you see carefully, cyclic GMP is metabolized. Cyclic GMP is metabolized by PDE5. So if you block this metabolism, cyclic GMP will increase. How can you block this metabolism? By giving PDE5 inhibitor. This is what is sildenafil and tadalafil. So that's all. These are the classes of drugs that you use in pulmonary artery hypertension. I hope you understood the chapter on respiratory system. This is what is important for the exam.